Very good. So before we move on to the final presentation by Dr. Dooling on phase 1 allocation of COVID-19 vaccine, the work group considerations, I'd just like to reiterate what was stated by Dr. Bell this morning. We're getting a lot of questions about the vote from the ACIP today, or not having a vote. It was mentioned at the previous meeting that we would have one. However, there is no vote today on prioritization for vaccination. Once the data is available from phase 3 clinical trials, the ACIP's COVID-19 vaccine work group will conduct an independent review of safety and efficacy data and present policy options to the full committee. If and when FDA authorizes or approves a vaccine, then ACIP will have an emergency meeting and vote on vaccine recommendations and populations for use. And so now we'll move on to the final presentation before public comment. Dr. Dooling, please.
Thank you, Dr. Romero. Good afternoon, everybody. Today I'll be talking about workgroup considerations for phase 1 allocation of COVID-19 vaccines. And this is really part and parcel of the presentation that Dr. Oliver gave before the break. Next slide. So once again, I'd like to ground the conversation in what the workgroup envisions as the overall goals of a COVID-19 vaccine program. First, to ensure that we have a safe and effective vaccine, that vaccines reduce the transmission, morbidity, and mortality of COVID-19 disease. The vaccine program helps minimize disruption to society and the economy, including maintaining healthcare capacity, and that we ensure equity in vaccine allocation and distribution. Next slide. From the beginning, the workgroup established guiding principles to help achieve those goals that I stated on the last slide. The number one, safety is paramount. Second, that clinical trials should be inclusive. And most pertinent to this presentation are the desire for efficient distribution of vaccine and flexibility within national guidelines. Next. And as you've already heard a number of times today, administration of COVID-19 vaccines will require a phased approach. Once a vaccine is approved for use, there will likely be insufficient supply to meet demand. Last month, ACIP heard about cold chain storage and handling requirements of -70 and -20 degrees Celsius, which may require specialized equipment and high throughputs at clinics. In the second and third phases of this vaccine rollout, we anticipate sufficient vaccine supply and a broadening of the implementation strategies to reach everybody who wants to be vaccinated. However, today, I would once again like to focus ACIP members' attention to the first phase, that projected short period of time where vaccine doses may be limited and administration will need to be targeted. How can we best achieve the objectives of the program during this period? Next. During the August emergency meeting, ACIP members voiced support for healthcare personnel to be offered vaccine during phase 1A. Phase 1B groups included essential workers outside healthcare, adults with high-risk medical conditions, and adults 65 years and older. During today's meeting, we will further explore these phase 1B groups, reviewing their risk for COVID-19, the overlap between groups, and their racial and ethnic composition. And then finally, a summary of the workgroup considerations for each group. Next. Before we begin, let me foreshadow where we'll end up with questions for the ACIP members. First question, if constrained supply necessitates sequencing of groups in phase 1B, what are the most important information gaps we need to fill for ACIP to make sequencing recommendations? And question number 2, what's the correct balance of national guidance and local flexibility? Next. So first we'll consider phase 1A, healthcare personnel. As mentioned, there was broad support from ACIP for inclusion of healthcare personnel in phase 1A of a COVID-19 vaccine program. And I'll review the group briefly here today. Healthcare personnel are defined as paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. The estimated population for this group is 17 to 20 million people in the United States. And although not exhaustive, some of the examples include people who work in hospitals, long-term care facilities, including assisted living, as well as skilled nursing facilities, outpatient, home health care, pharmacies, EMS, and public health. Next. The table shown here indicates information that either supports early allocation of doses to healthcare personnel or will pose a challenge. Equity considerations support early vaccination of broadly defined healthcare personnel, as there's high representation of racial minority groups in some healthcare settings, such as long-term care and home health care. As you heard in the previous talk, all values-based allocation frameworks the work group reviewed included healthcare workers in their earliest allocations. Feasibility considerations mostly support healthcare personnel, as at least large healthcare systems have occupational health departments to facilitate vaccine clinics, and they may also have -80 freezers. However, it will be more challenging to reach rural healthcare facilities, long-term care facilities, small independent clinics, and home health care workers. Importantly, we will not be able to assess the benefits or possible harms of any particular COVID vaccine until the clinical trials are complete. Next. I'll next discuss Phase 1B, essential workers, not including healthcare workers. Next. CISA, within the Department of Homeland Security, is responsible for creating a list of workers who are essential to continue critical infrastructure and maintain the services and functions Americans depend on daily. Their guidance acknowledges that workers who cannot perform their duties remotely and must work in close proximity to others should be prioritized for mitigation measures. It's also important to recognize that subcategories of essential workers may be prioritized differently in different jurisdictions depending on local needs. The estimated population for this group, again, not including healthcare personnel, is 60 million people. Although not exhaustive, some examples include workers in industries such as food and agriculture, transportation, education, energy, water and wastewater, and law enforcement. Next. Although few specific surveillance systems for COVID-19 exist within critical industries, there are numerous examples of outbreaks affecting these workers. By July 2020, hundreds of outbreaks had been documented at meat and poultry processing plants, affecting hundreds of workers, and similarly, corrections and detention facilities, residents and staff have been hard hit. In New York City, seroprevalence among correctional facility workers and fire department workers on the front lines exceeded those of the general population. Next. There is a significant proportion of essential workers who also have high-risk medical conditions. That ranges from about 30% of essential workers with obesity to about 2% with chronic kidney disease. And although the overlap among medical conditions is not shown here, it's estimated that more than a third of essential workers has a medical condition, putting them at high risk for severe COVID-19 disease. Next. Essential industries may vary by the prevalence of high-risk medical conditions among their workers. For example, transit and postal workers have a slightly higher than average risk of cardiovascular disease, while workers in trucking have disproportionate prevalence of obesity and diabetes. Next. The racial and ethnic composition also varies among essential industries. Racial and ethnic minorities account for about 37% of US adults, but more than 50% of transit workers and utility workers. Next. In fact, compared to all workers, Black workers are overrepresented among frontline industries considered here. Hispanic workers are overrepresented in industries such as trucking, warehousing, and building and cleaning services. Next. And despite performing work essential to the functioning of society, 23% of essential workers live in low-income families, defined as income less than 2 times the poverty line. Next. Moreover, 10% of essential workers have no health insurance. That reaches as high as 30% in industries such as cleaning services. Next. There's also overlap between essential workers and older adults. Approximately 16% of essential workers are either 65 or older themselves or live with someone who is. Next. So the work group's summary of the considerations are thus. Overall, equity considerations support early vaccination of essential workers, as there is high representation of racial and ethnic minorities, and many workers may be in low-income families or have no health insurance. Although all values-based frameworks the work group reviewed recognize essential workers for early vaccination, they differed in their prioritization of specific industries. It's still largely unknown how essential workers value COVID-19 vaccination. In terms of feasibility, essential workers are generally mobile, and vaccine points of dispensing may be deployed to work sites. Because essential industries vary by jurisdiction, states will likely have to make prioritization decisions which will exercise local flexibility. On the other hand, prioritization exercises will increase workload and create the potential for differences from state to state. And finally, the acceptance of COVID-19 vaccine among essential workers is not precisely known. Next. Next, I'll discuss the Phase 1B group, persons with high-risk medical conditions. So focusing on adults with medical conditions at higher risk for severe COVID-19, the estimated population for this group is over 100 million adults in the US. This is a rough estimate and may change as we gain evidence about the conditions which confer risk. The current list of conditions is here and available at the link at the bottom of the slide. The percentage of adults and population with selected medical conditions ranges from approximately 31% with obesity to 3% with chronic kidney disease. Next. In terms of risk for COVID-19 disease, nearly 90% of hospitalized adults had at least one high-risk medical condition, and over 60% had 3 or more. Obesity, chronic kidney disease, and hypertension are associated with hospitalization for COVID-19. Among hospitalized COVID-19 patients, the adjusted rate ratios for underlying medical conditions associated with death ranged from 1.19 for diabetes to 1.39 for immunosuppression. Next slide. The prevalence of selected underlying conditions varies by race and ethnicity. For example, the prevalence of diagnosed cancer, chronic kidney disease, and cardiovascular disease is either similar across racial and ethnic groups or higher in whites, whereas prevalence of diabetes and obesity was highest among American Indian and Alaska Natives. Next slide. A summary of the workgroup considerations is as follows. Equity may be challenged by early vaccination of adults with high-risk medical conditions because diagnosis of these conditions may require access to health care. The allocation frameworks reviewed all support persons with high-risk medical conditions as early phase vaccine recipients. Supporting feasibility of vaccination, persons with medical conditions are often connected with healthcare. But on the other hand, the number of people in this group, which numbers more than 100 million, will likely require sub-prioritization if vaccine supply is constrained, which will be difficult considering the high degree of overlap between conditions like obesity and diabetes. Moreover, assessing medical eligibility within the context of a mass vaccination clinic is logistically challenging. In terms of acceptability, this group has moderate influenza vaccine coverage, but we don't yet know how this group will view acceptability or value phase 1 receipt of COVID-19 vaccine. Next. Next, phase 1B, adults 65 years and older. The final group that I'll highlight today is adults who are 65 and older. The group is estimated at approximately 53 million persons in the United States. And this accounts for approximately 16% of the US population. And of note, approximately 3 million persons currently live in long-term care facilities. Next. In terms of COVID risk, adults 65 years and older represent 16% of COVID-19 cases, but nearly 80% of COVID-19 deaths. Adults 65 years and older have the highest cumulative rate of COVID-19 associated hospitalizations, and older age is the strongest independent factor for in-hospital death. Next. Hispanic or Latino persons account for almost 18% of the total US population, but only 8% of the population 65 and older. 77% of this group are white, and racial minority groups all comprise a smaller fraction of people 65 and older compared to their proportion in the overall population. Next. According to the National Health Interview Survey, approximately 39% of adults 65 and older have a medical condition that puts them at high risk for severe COVID-19 disease. Next. When considering early vaccination of adults 65 and older, a challenge to equity is the underrepresentation of racial and ethnic minorities among older persons. Some allocation frameworks support the early vaccination of older persons, especially those living in congregate settings, while other frameworks suggest that older persons living at home and without underlying medical conditions should be vaccinated in phase 2. In terms of feasibility, persons 65 and older usually have access to Medicare, and a high proportion have a regular place they receive health care. However, if mass vaccination clinics are necessary, mobility and social distancing may be difficult for some in this age group. As for acceptability, older adults have moderate influenza vaccine coverage, but we don't yet know how this group will view acceptability or value early vaccination with COVID-19 vaccine. Next. To recap, we've reviewed the workgroup considerations of 3 possible groups for phase 1B vaccine allocation. The workgroup has articulated some key unknowns which hamper more detailed sequencing for these groups. First, there are multiple vaccine characteristics that we don't yet know, such as the magnitude and balance of benefits and potential risks, the storage, distribution, and handling for cold chain requirements that have ramifications for implementation, and if the vaccine efficacy and immunogenicity will be different in younger versus older recipients. Another unknown is if the vaccine will be approved under an emergency use authorization or licensure, and which populations may be covered. And finally, we don't yet know the number of doses that will be available at the time of approval or the rate of scale up. Next. As for next steps, the workgroup will continue to build scientific understanding of the epidemiology of the phase 1 groups, modeling the impact of various vaccination strategies, and interpretation of early clinical trials safety data and plans for post-marketing safety monitoring. The workgroup will prepare the evidence to recommendation framework for vaccines in phase 3 clinical trials, including preparing an equity domain, gathering evidence on values and acceptability domains, among others, and grading safety and efficacy from phase 3 data as it becomes available, and preparing policy options for ACIP consideration. Next slide. Now I'd like to return to those questions I introduced at the beginning of this presentation. If constrained supply necessitates sequencing of groups in phase 1B, what are the most important information gaps we need to fill in order for ACIP to make those sequencing recommendations? I'll pause there and turn the conversation over to the chairs.
So we open this up to discussion and comment from the voting members of the ACIP, and then we'll turn to the liaisons and ex officios. ACIP members, please weigh in. Dr. Szilagyi.
Yes, thank you, Dr. Dooling, as always, for a really great presentation. And it's very clear. One component of the information that would be helpful for me, at least, to be very clear about serious COVID infection and death, separating that from infection as the outcome from COVID infection. Because it may be that, for example, many essential workers who do not have chronic conditions or are younger may have a very high likelihood of, in some groups, of infection and a higher or lower likelihood of mortality. So serious infection. So data on serious infection, which I think we already have, would be. And then the other point I want to bring in here is it's interesting that none of the paradigms have specifically called out older adults in long-term care facilities or the staff that serve them because of the evidence that was presented previously at another meeting about the importance of vaccinating staff around them. So that is one group within the 65-year-olds that I think might be an important subgroup to call out. Thank you.
Thank you. Dr. Paling.
Thank you for a fantastic presentation. One of the things that I would really like to understand is in our hotspots, what % of those have been due to essential workers? And then the second component will be looking at the acceptability in each of these different groups, which is an important and highlighted concern. As I'm working through the goals that you have set out, the essential workers would decrease transmission and morbidity and mortality, and that's why understanding the hotspots would be really important. It would minimize the society and economic benefit, and it would address equity. And so more information on that group would be most helpful. Thank you.
Dr. Bernstein.
Thank you, Dr. Romero. Wonderful presentation, and all of them today have been fantastic. I certainly heard overwhelming support, and I agree wholeheartedly with the principles of the frameworks that have been presented and how consistent it is with NAM and World Health Organization and Hopkins. And I think it's important as we explore the ETR of this for us to use these principles, not just with the allocation, that is prioritizing these groups, but also using the frameworks with the distribution, meaning being able to get the vaccine to those prioritized groups, and also the administration of the vaccine, meaning getting the vaccine actually into those prioritized groups. So along those lines, and when you ask about what are some important information gaps, I do wonder how we can factor in the limited acceptance that some of these groups may have. And you outline that in a number of your slides where you emphasize that we don't know how they value the vaccine. But I think we might have to sort of think about some mathematical modeling as far as varied rates of acceptance of the vaccine, which will in turn impact distribution and administration of it. Thank you.
Dr. McNally. I'm sorry, Ms. McNally.
Thank you. Can you clarify regarding V-Safe's use for the other populations in phase 1B. So I think in the slides it indicated it would be used for essential workers, but could it be used for the other categories as well?
Yes, that's the question open for discussion. I apologize. If the question was about VSafe, the safety system, monitoring system that you heard about during the safety presentation, which is initially going to roll out among healthcare personnel, if that could be used among additional essential workers, excuse me, that I misheard your question in the beginning. I think that is a great suggestion, and I will bring it back to our safety experts.
Thank you.
Dr. Hunter.
Yes, thanks for this wonderful presentation. Early on, when there's a constrained supply, it's going to be really difficult for the state and local health immunization program directors to allocate the vaccine that they have control over to particular venues and deciding which ones to go with first. So I'm thinking within the Group 1B, as much differentiation as you can and much information you can get to rank them in maybe a rank list of the different subgroups as small as you can make those subgroup divisions that you have time to and information on. If you can rank those relatively, then it might be able to sort of turn it over to the state and local folks to just look at their own populations and say, okay, this venue we can get the highest risk people taken care of if we allocate the vaccine to this venue. I'm just wondering if that is a reasonable way for you to approach giving us more information and, even more importantly, giving state and local immunization program managers that kind of information. Thanks.
Thank you, Dr. Glickman.
Yes, I have 3 points I'd like to make. The first one is related to, it's been echoing a couple of points made about the importance of hotspots. In just thinking about how large the pool of essential workers is, might it make sense to move essential workers in hotspots into group or phase 1A? This might also address some of the concerns that people have about making sure that there's priority for disadvantaged populations using the Social Vulnerability Index, because we saw a correlation between SVI and hotspotting, and I think that it might have more impact. But I think getting 80 million doses in addition to the 20 million is going to deprioritize essential workers and hotspots. The second point I'd like to make is that in low-income areas, the access to facilities that can provide the vaccine may be more challenging, and there may need to be more emphasis on mobile van distribution, if that can be done, to ensure vaccine access in disadvantaged populations. And the third is while we're prioritizing groups, up front, I haven't heard anything yet about the importance of operationalizing access to their second shot to ensure that the vaccine doses that we give are effective. And that really needs to be part of the implementation process. Thank you.
Thank you. Liaisons, any other questions or comments, work group members? Any other comments? Dr. Lee.
Thank you. One of the things that I don't think we'll be able to answer for this particular question is going to be the impact, and I don't know if Dr. Szilagyi or somebody else brought it up, but the impact on those with severe disease versus transmission. And the reason that might be important is because in certain categories or populations, we might be more focused on preventing severe morbidity and mortality, and in other populations, maybe more focused on the prevention of transmission. I also, just to respond to Dr. Hunter's comment, I have been struggling with this in part because we don't know what the benefit-risk balance is going to be for any of the vaccines. So, for example, if the benefit-risk balance in adults over 65 looks quite different than in younger adults, that might influence the ordering and vice versa. And the other question is going to be if we have benefit-risk balance that is extremely favorable versus moderate. That also, in my mind, influences the approach we might take because we do want to maximize the benefits and risks in any given population. But it will really depend on the characteristics of the vaccines that come out. Thank you.
Thank you for those comments. Anyone else? I think that's it. Dr. Bernstein?
I just wanted to mention also about that perhaps is an important information gap here is that we don't know how children, the pediatric population, fits into this equation as well. And I think that may also factor in some way, since they won't be immunized, but certainly interface with all of these groups of adults.
Thank you. Anyone else? I will turn it back over to Dr. Dooling.
Thank you. I'd like to move on to the second question. Next slide. Which is, considering all the groups that we've discussed, what is the correct balance of national guidance and local flexibility?
So I'll begin. I think there has to be some degree of local flexibility within the boundaries or guidelines that we establish or that ACIP establishes. In part because that is going to be important in delivering vaccine to the number of significant groups that we have listed here. So again, I think there has to be some degree of flexibility, but again, the boundaries should be respected. Hank, your hand is still up. Is Dr. Bernstein, is that a leftover?
Yes, sorry.
Okay, no problem. Dr. Atmar.
Thank you. I want to argue for maybe a little greater national guidance because it's at this level where there's the greatest transparency. And at least my experience has been as it trickles down to intermediate and local control, the transparency is not always quite as great. And so and that may be unique to me, but I'd like a little more national guidance. Thank you.
Thank you, Dr. Paling.
Thank you. This is a really delicate and important question. From my perspective, the national conversation as well as the guidance is really important. And the more we can make this easy to implement and easy to follow, the better I think we'll be. There will need to be some local flexibility, but the more we're similar across the country and don't have wide variations, I think the more transparent and better this process will go.
Thank you very much. Dr. Szilagyi.
Yeah, I agree. This is a really difficult balance. It seems to me that we have some clear sort of domains that should be at the national level, such as the benefit and risk for transmission or the benefit and the risk for death or hospitalizations. That that kind of guidance can be transmitted nationally, or the vaccine effectiveness early on, interim effectiveness for an entire population, or let's say over 75 years old, or subgroups. But it's at the local level that local public health officials will need to know whether they are a hot spot or not, and that will change over time. Also at the local level, it's the local authorities who know the prevalence of different kinds of essential workers. So for example, meat packing or other, there's whole areas that don't have any, and there's of those kinds of essential workers, whereas others have a lot. Also at the local level, they will know their delivery mechanisms and some of the implementation, the practical aspects. And finally, they might have a sense of the values of the population, although that's difficult to get. But I think those would be more difficult to achieve at a national level. So to me, there really is some kind of a balance between national guidelines and local flexibility. Thank you.
Dr. Messonnier, please.
Yeah, not to reply to that, but just to maybe put something out there that I think we talked about multiple meetings ago. But, I'm a little troubled by the idea that we can use hotspot analysis to make decisions about how to target vaccines, given that, unfortunately, our hotspot analysis don't predict very far out, and certainly may not predict out past the second dose of vaccine if it's a 1 in a 28-day vaccine, and then takes another week for the vaccine to be effective. And I guess there may be other reasons why to target hotspots. For example, it may be a good place to really ensure that folks understand the risk and we can communicate it and there could be good uptake. But I'm troubled that we need to be careful as we communicate this to state and local health departments that we don't inappropriately suggest that these current vaccines would be a tool, a short-term tool for controlling their outbreak. Thank you.
Excellent point. Dr. Zahn.
Yeah, I guess I just wanted to follow up with Dr. Szilagyi's point and completely agree with what he's saying. The appearance of the outbreak in your community changes a lot over time. And I certainly get what Dr. Messonnier is saying, that you don't want to just go, and chase it around. At the same time, if we're talking about a period of time, say 6 weeks, 2 months, where you anticipate a vaccine shortage and your schools are all closed, and you know that most of your schools are not going to be opening for 2 or 3 months, or you're in a situation where your restaurants are closed or not closed, it is really appropriate to be aware of what's going on in your community, and I really do think it's going to, that reality has to drive your response in a community, and then local public health, we have to be given the flexibility to react that way.
Dr. Lee.
Thank you. I just wanted to state that, the national guidance, I think, can provide high-level recommendations or principles that drive implementation, but the local level is clearly where the implementation actually happens. So I do feel like preserving the autonomy of local leaders who are critical in supporting the implementation and perhaps know better than us about how to implement in their areas would be really important for us to preserve. One suggestion that I might have is to have some implementation metrics that are important for accountability. And the one that comes top of mind to me is thinking about equity and whether or not we can measure that in terms of distribution and administration. That's probably the most important from my perspective. And I'll go back to the social vulnerability index as a tool. So rather than focusing on hotspots, where I agree that I think that by the time the hotspot comes and goes, it's going to be a challenge to make sure that we can get the vaccine in there in advance of a hotspot occurring. Nonetheless, I do think that we know which communities are at risk, independent of disease activity, and would still want to advocate for being able to reach those communities as a priority population.
Dr. Bernstein.
Thank you. Yeah, I wanted to echo what others have said, that I do think that national guidance is so very important in my mind when we're thinking about the delicate issue of balance. But I do think there's currently an imbalance, and I think we need much more of a national guidance at this point. But I would also say at the same time that operationalizing the national guidance at the local level and allowing flexibility at the local level is also important.
Thank you, Dr. Tallett.
I would like to confirm, or maybe that's not the best term, but Dr. Messonnier talked about this is really not a tool for hotspots. And this vaccine, the way it needs to be stored and used and drawn up, and it is not going to be used for hotspots. It just won't be feasible. The planning won't work. I think when we talk about the flexibility for local governments, it's not which hotspot or not. It's, is your community a meatpacking plant? Is your community a strawberry farm? Or is your community something else? So I think that to us is the idea is that you're able to keep those workers who are working and cannot work from home safe. Thank you.
Thank you, Dr. Gluckman.
Thank you. The questions today have been, this discussion has been, talking about local versus federal guidance. But has there been any thought about how the vaccines will be distributed among states? Because again, I think that the disease prevalence in hotspots is an important consideration in how many doses are delivered to the states, so that they can then use the flexibility needed to deliver to local communities.
Dr. Messonnier.
Yeah, again, I think as several folks have said, it's really not, it is very clear that these first vaccines are not amenable to outbreak control. So I'm not really convinced that hotspot analysis is going to play a major role in decision making. And what I would say about allocation is that, part of the major decision around allocation will be driven by the ACIP recommendations. That is, and therefore it is difficult to say in the absence of specific information about the vaccine and specific information about the priority groups exactly how vaccine will be allocated. But as many folks at the state and local health departments know, in order to do planning, we have given states at least the broad outlines of some scenarios that we think make sense in terms of prioritization as a starting place. But again, part of what CDC looks to ACIP for is to help us by making those very specific recommendations.
Dr. Sanchez.
Thank you. I agree with what's been brought up. There definitely has to be some national guidance because it's otherwise, and that's what we're here for, and that's what ACIP is here for, to make that national guidance. But there's no question we're going to have some local flexibility because we may also see very marked differences in vaccine uptake, even among certain what we would consider higher risk individuals on a local basis. And in which case, then we have to have some flexibility in terms of selecting or seeing who are the optimal candidates for the vaccine while it is still in limited supply.
Dr. Lee, your hand is still up. Do you have another question or another comment?
No, thank you.
Okay. Dr. Gluckman?
I need to put my hand down, thanks.
Thank you. Dr. Fry?
Thank you. Very nice presentation. Thank you so much. I just want to mention, having to work with regulatory affairs as part of my life, that it is important that we have national guidance, of course, and it's necessary, but we need to be careful that the level of guidance is not too granular such that it bogs down or paralyzes vaccination campaigns because of complex decision making and, of course, data gathering and paperwork that would be needed. It would be best, as discussed earlier, that the states and communities make plans about how they're going to distribute and administer the vaccines, such that the process is as efficient as it can be. And this, of course, would need to be done before they are shipped product to distribute and to administer. And so that front planning will be most effective in being efficient, but I would also argue that too much oversight is not always the best choice.
Thank you, Dr. Hunter.
Sorry, I had to unmute. I was wanted to speak in support of what Grace Lee said as far as accountability and having metrics for that. And as I was thinking of it, I was thinking of my parenting style in that trying to give broad outlines and just letting them know I'm watching them was very helpful in raising my children who are now in their 20s. And just definitely keeps them on their guard. And I think that, if we do provide nationally as much guidance for the components of how the decisions should be made, and then we just follow up with what decisions were made as real time as we possibly can, and just say, hey, yeah, looks like you're following the guidance from the way we're interpreting what you did. The more we can do that, the better things will go, in my opinion. Thanks.
Thank you. Dr. Fry, do you have another comment? No. Okay. Any other comments, questions, liaisons? Dr. Freihofer.
Sandra Freihofer, American Medical Association. This has been just a fabulous discussion, and I appreciate the thoughtfulness of ACIP as we think about these issues. The AMA actually submitted a paper to the work group on based on the AMA Code of Medical Ethics, allocating scarce vaccine supplies in a public health crisis. And one of the topics that was raised in this document is a distribution based on the geography of need, and perhaps in some instances that might be preferable ethically to putting foundational values into play. And in this, the geography of need, we mean an approach that determines the number of vaccine doses provided based on identifying those communities where, based on the available evidence, access to vaccine supplies could reasonably be expected to have the greatest effect. And such decisions might take into account such factors as known or emerging hotspots, and greatly appreciate Dr. Massonier's comments about that, but also structural factors that influence the risk and rate of transmission, such as population density, demographics, and living conditions. So this approach is sort of different than what we normally do and would require an infrastructure for data collection and would likely demand new channels of communication and coordination, and I think would be things that could only be accomplished on looking at this at a local level.
Thank you. Any other comments? Very good. I think we'll move on back to Dr. Dooling. She's signaling to me that those were her questions, and we've addressed them. Okay, so do you want to go on? So we'll move on to the public comment section here. We're going to take Oh, we have to break until, I'm sorry, forgive me. Dr. Cohen is telling me that we need to wait until 3:45 when our actual scheduled public comment section is. So we have 40 minutes, please. And we will reconvene at quarter till the hour. Thank you very much.